Who told you about it?
Alright. So periodontics. What is periodontics? Periodontics is the specialty that focuses on the prevention and treatment of gum disease or periodontal disease. Hi.
Hi. What did you do?
Periodontal disease, a general term used to describe the many disorders of the periodontia. Periodontal disease is the most common cause of tooth loss in adults. So it's not cavities, usually it's advanced bone loss. Not good. So a healthy periodontium, again, periodontium, if you remember, is what?
The gums.
Gums?
And the bones.
Yes. Gums, bones, ligaments, all the package, okay, not just the gums. Okay, it's the gums and all the supporting structures. Uniformly pink in Caucasian people and pigmented in people of color. Free gingiva, firm and smooth. Okay. The attached gingiva, stippled texture, similar to an orange peel. If you look real carefully on people that have a really healthy attached gingiva or really healthy tissue, you'll see this. Marginal gingiva fits tightly around the tooth, 1 to 2 millimeters above the CEJ. Again, the margin is that little pocket, that loose tissue. So again, this would be a really healthy gingiva. And if you look right here at the attached gingiva, which is the really pink, not the reddish down here, this from here up is what we call attached. Okay, and if you look kind of this, in this area, you'll see the stippling. Kind of an orange peel length. Okay, and that's what we want to see. We don't normally see that. Cementum. Okay, you guys remember cementum from a few weeks ago?
Yes.
It's what? What covers the root. Okay, it's the hard structure that covers the root. The enamel is a hard structure that covers the crown. The cementum is the hard structure that covers the root. And it provides attachment for the PDL fibers up to the CEJ. Periodontal ligament, its function is to connect to the tooth cementum to the lamina dura within the tooth socket. The periodontal ligament fibers should be free of inflammation. The alveolar bone provides support to the teeth and also blood supply to all the tissues. The crest of the alveolar bone should be close to the CEJ. So CEJ is the cemento-enamel junction, where the cementum and the enamel join. Where the enamel stops, that's what we call the CEJ, and the bone should be about 2 millimeters from that CEJ, ideally. Okay, so here's the CEJ right here, and here's the bone. So you want it pretty close to that area. As gum disease progresses, you know, this bone is going to go down. Here's the CEJ right here. Bone is going to go down. You've got all those fibers going every which way that help support the tissue. Factors that contribute to gum disease. Plaque. You don't brush your teeth, you get gingivitis. You know, clear gingivitis, it progresses to periodontitis, which is loss of supporting structures. So the plaque contains acid-producing bacteria that irritate and inflame the tissues. If you don't remove plaque, just the minerals in your saliva will get calcified, and it creates a roughness which irritates the periodontium. Again, it forms, you guys, and calculus is a natural process. I mean, that's why every 3, 4, or 6 months patients are brought back so that we can control this. Because even if you brush and floss every day, you're getting some degree of calculus. Okay, and if it's not removed, once you get calculus, even the floss won't break it through, and that's why you have to come so that it can be kind of picked off and polished off. Because I guarantee you, and granted, some patients, they can go a year and they come in and they've got very little. Some patients can go 3 months and it looks like they haven't been here for 2 years. It's just a difference in their system. Loss of bone height will cause gum disease. It can be chronic, sustained inflammation that causes a reduction in bone height, and obviously tooth support as the tooth goes down, as the bone goes down. Sensitivity to thermal changes and palpation of tissues. So if you drink something cold or you touch a tooth and it hurts, something is sensitive, it's going to cause you to stay away from that tooth. You're not going to brush it, you're not going to clean it. Again, you're going to end up with gum disease. Diabetes, this is a really common one. You know, patients with diabetes, they can't control, or their body can't fight infection as well as healthy individuals. So gum disease is really, really prominent in diabetic patients. So it's really important that we educate these patients. And I just had a little boy, saw him for recall this past week, Tuesday or Wednesday, or Janice actually saw him, and I went in and I said, "Hey," I remember Michael, I think, "Michael, how you doing?" And he goes, "I have diabetes." He's, I don't know, probably 10, 11. So, "Oh, Michael, I'm sorry to hear that, but hey, you'll be all right. You take insulin?" "Yeah, I have to take insulin now." So again, some of these kids, and I said, "Well, Michael," and I told him exactly this. "You know, Michael, you'll be fine." I said, "But as far as your teeth, patients that have diabetes, it's really critical that you brush and floss and keep your teeth very, very clean." And I told him, because as you get older, it's a possibility that you can end up with gum disease. So, okay. So again, start educating them at this age so that they start taking care of their teeth. But he just, "I have diabetes."
So sad. That's so sad.
Acquired, I will say, not playing football or something.
Yeah.
So AIDS, a disease which suppresses, again, the immune system and contributes to rapid progression of gum disease. And again, I see HIV patients, have quite a few patients, and usually, as long as they maintain, same as diabetes, as long as they maintain a clean oral health, oral environment, brushing, flossing, it's controlled. But once they get into AIDS, towards the end, then it's a rapid progression. And then other disorders of immune system. Again, anything that deals with the immunity of your system is going to contribute to possibility of gum disease. Why? Because gum disease is kind of a chronic infection. And if you can't deal with it, your body can't deal with it, it just gets worse and worse. So what are some of the signs and symptoms? Bleeding. A patient on Wednesday saw him, and he goes, "Hey, Doc, I got a question for you. Not about me, it's about my mom," he says. I said, "Oh, what's going on?" "Oh, well, when I take out her dentures in the morning or at night, I see that she's got blood." I said, "Well, what's going on? Does she have a full upper denture?" "Well, she's got some teeth on the lower front." I said, "I bet you it's probably some gingivitis or some gum issue, so bring her in." But again, bleeding is usually a sign of inflammation, unhealthy gum tissues. Discolored gingiva. Sometimes it's reddish, in just gingivitis, it'll be reddish. As it progresses, it could become bluish or purplish. Again, as you build up calculus or tartar underneath the gum, and it matures, the older that tartar gets, it changes color, it turns darker, it puts more pressure on the gum tissue, and that gum tissue will change colors. You'll have swelling, just like any inflammation. Again, you get a splinter on your finger, it swells and turns red until you pull that splinter out. Your gums will do the same thing. And again, the pocket depth is how we measure this inflammation. We put the perioprobe and we go down until we hit resistance, and that's how we measure the gum disease. Ideally, gum disease or gum pocket should be 2 to 3 millimeters. Anything above a 4, you got beginnings of gum disease. Above an 8 is advanced gum disease. And obviously, this is a giveaway there. Sometimes you walk into the room and you already know what you're going to see. I mean, it's that bad sometimes. You walk in and period. And loss of loosening of teeth is another one. And what's this? Bad bite. The teeth are going to be moving. So what are the stages? Initial, gingivitis. Okay, gingiva, gums, itis, inflammation. So gingivitis, inflammation of the gums. Inflammation limited to the gingiva can be reversed by utilizing preventive measures. So if somebody's got just gingivitis due to plaque, you help them brush their teeth, give them some oral hygiene instructions, tell them to brush and floss daily, maybe put them on a mouth rinse, and they'll be 180 degrees the next time they come in. I mean, it's like black and white. They begin to do what you tell them. Does not cause bone loss at this stage. Can be caused by plaque accumulation. We see this hormonal changes or vitamin C deficiency. Sometimes during pregnancy, there is a condition called pregnancy gingivitis. Again, due to hormonal changes, your body's busy doing other things, so the gums aren't as important, and you can get some gingivitis due to pregnancy. So again, here you see some gingivitis around, the collars of these teeth, and brushing and flossing, and you can see some decrease in their inflammation around those teeth. So gingivitis, it is reversible. What are the stages? Stage 1 of gingivitis is the initial clinical signs is inflammation. Stage 2 is going to be redness and bleeding on probing. Stage 3, long-standing chronic gingivitis appearing bluish under the reddened periodontia. So stage 1, a little bit of redness. And this is obviously a little bit more advanced, and you'll see the change in the tissue color. Sometimes it'll be red, sometimes it'll start to turn blue or more magenta. And as soon as you put your perioprobe here, it just goes, it just gushes. And again, you go in there, clean it out, and usually it'll go away as long as we don't have any bone loss and they can maintain it. If they don't maintain it, it progresses to periodontitis, which is inflammation of the periodontia. Now it's not just the gums, it's not just gingivitis, it's periodontitis. Okay, where we have inflammation involving the periodontal ligament and the supporting structures. The pocket is formed when the plaque and debris accumulate within the gingival sulcus. The pockets are greater than 3 millimeters. So now not just 1, 2, or 3, but now we start getting into 4s, 5s. So we're starting to have a little bit of detachment and maybe some bone loss. So periodontal fibers attaching the tooth cementum to the lamina dura of the tooth socket become diseased. The stages of gum disease or periodontitis. Early periodontitis occurs when inflammation progresses to the alveolar bone crest. Pocket depth formation is between 2 to 4. Bleeding on probing, sensitivity, poor hygiene. Okay. Early periodontitis We probably won't get that pocket, after we clean, we'll probably get that pocket to go down maybe a millimeter or so after a cleaning, and hopefully control the bleeding. If they've lost bone, the bone you will not regenerate. Once you lose bone, that bone will not regenerate. Moderate periodontitis, we've got continued destruction of the periodontal structures. Pocket depth is between 5 to 7. Okay, so 2 to 4 is early, 5 to 7 is moderate. And then the furcation, who remembers what the furcation is? You've got bifurcation on the bottom, trifurcation on the top. It's where the roots, the tooth roots split. Okay, so in periodontitis, in moderate periodontitis, when we check, we start to feel that separation of the roots. Okay, remember when you did charting, you had a class 1 furcation where you put an inverted triangle. Class 2, you closed the triangle, meaning you could feel a little bit, but you couldn't go all the way through. Class 3 means that furcation is through and through. You can put your probe and go to the other side. Okay, so in moderate, space between the roots, multi-rooted teeth may occur. There could be some mobility. Then advanced periodontitis, you're definitely going to have furcation on molars. Increased pocket depths of 8 or more. Includes tooth mobility and furcation involvement. Not necessarily. You know, you can have a tooth with advanced bone loss. It could be a little bit mobile. Patient turns their
When my mom went to my boyfriend's tooth yesterday, it was like 9. Yeah.
That one that has that?
Well, it was his wisdom tooth.
Oh, that's not uncommon on the wisdom area. Okay, especially like the distal of second molars. If you have an impacted wisdom tooth, you've got your impacted wisdom tooth. You probably don't have bone there.
Yeah.
So you go between the second molar and the wisdom tooth, and you're going to get a new pocket.
So he should just get it right.
Possibly. Get any value looked at.
Yeah. He's like, oh, I don't want to be awake for it. I'm like, don't be such a baby. It's fine. I'm fine.
I'd get put under.
Really? I don't know.
Sure, if it's impacted,
Yeah,
and it's probably not that. Probably get them all taken out if you need to.
you're done.
But anyway, so know these stages: 2 to 4, 5 to 7, 8 or more. Okay, for the incipient, or early, moderate, or advanced. So again, here's in case you walk in and it doesn't look that bad. You get your probe, and again, probes. You get
Seeing
bleeding.
that, when I went to shadow, I seen the dentist and hers started bleeding a lot like that and it was growing it.
Oh, where you went to shadow? Yeah, I mean, it's not uncommon, you know. See it all the time. I mean, I think you've got these, so healthy tissues, 3 millimeters or less, gingivitis, redness. Do you have this? Did I get? Redness and slight bleeding upon probing, no pockets beyond 3, bleeding upon probing, inflammation progressing to alveolar bone crest, 2 to 4. Moderate is 5 to 7 with some discoloration of the tissue, and then some furcation probably you're starting to feel, and advanced above 8 and definite furcation and mobility and bad breath. Again, they've linked these. We try to tell patients nowadays they've linked these gum disease and the bacteria nowadays to other systemic problems, because you're swallowing all this bacteria, and they find this bacteria present, in patients that have had, cardiac problems, heart attacks, diabetes. They find it in low birth weight babies nowadays. They're linking it to all kinds of stuff now. So, even though we're just dealing with teeth and gum disease, it's affecting, your whole system. And it's kind of a different approach to take in patients. Hey, we had a patient just the other day who went to take a blood pressure. Oh, I don't want blood pressure taken. What's the first thing they do when you go to your physician? You get on the scale and they take your blood pressure. Well, here we're going to give you some anesthetic. I need your blood pressure. I don't want blood pressure. All right, see you. Again, here's you know, furcation involvement, and sometimes, you know, it's just the anatomy of the teeth. Again, sometimes just the complexity of the root structure and the way the teeth are formed makes it really difficult for patients to keep them clean. Again, you'll see it a lot on maxillary first molars because they're bifurcated. They have two roofs, and you'll see gum disease on the front part of a first premolar, and real common on maxillary first molars. Again, just because of how the teeth are, how the teeth bites, and some patients just get localized gum disease on one tooth. It's weird. But you see that you walk into the room and it's, as soon as you walk in, it's gonna go, whoa. Let you know something's going on.
If you couldn't tell.
Well, yeah, just by the odor usually. Just you walk in, it's like, ooh, I know what's in there. Something not nice. Systemic diseases contributing to periodontal disease. Again, some systemic problems. Again, we talked about diabetes. It's usually periodontal disease is very prevalent in diabetics. Symptoms may include overgrowth of the gingiva, alveolar bone loss, periodontal abscesses, and pain. Epilepsy. Okay, epilepsy, it's not as bad as before, but still, there's some medications, and this is the one you need to know, a drug called Phenytoin or Dilantin is a common drug given to epileptic to control seizures. It's not as used as much anymore, but Dilantin experiences overgrowth of the gingival tissues. The overgrowth of the gingiva tissues can be treated by good hygiene, and sometimes you have to go in there and remove it. And I've done a couple of these surgeries. It's usually very messy. Gingival, this is, I think you have this again. You'll have the gum tissue just kind of overgrow. This is kind of what it looks like in the mouth. Sometimes you can barely see the teeth. You go in there and just kind of smoke out the teeth because you don't see it. But this is a response, a secondary response to a medication. So you go like that, and then after surgery and healing, obviously here.
Have you seen that before?
I have. I've done surgery on this. I think I did 2 surgeries when I was in my residency. Yeah.
They're tall though.
There's all.
Leukemia, again, we saw this in our pediatric lecture. Again, overproduction of white blood cells. Clinical signs include gingivitis, bleeding of the gingiva, and hemophilia, lack of one of the essential clotting factors in the blood. These patients must be diligent with home dental care without causing abrasions to the soft tissue. Obviously, you want to get a bleeding. If they get gingivitis, you know, if they brush their teeth, they're going to bleed. And if you're a hemophiliac, that's not good. So again, we've seen this picture. Leukemia. It's just a little picture. Some of the stuff you can see in the mouth there. And the patient may think that it's something due to the gums, but it's not. AIDS, due to the lack of adequate immune system. We talked about ANUG. This is the one that really, you walk into the room and you go, ooh, something's in there. A destructive infection of the gingiva characterized by bad breath, ulcers in between the teeth, a necrotic tissue in the mouth, and general feeling of illness. Okay, and you can see these areas, and this isn't that bad, you can see the areas of necrotizing or dying tissue. Okay, so it's called acute necrotizing ulcerative gingivitis, ANUG. really, and you see this one here. You can see the gum, the tissue just kind of dying there, sloughing off, and you touch those and they bleed, and you can get pus draining from those. And those we send them off to the periodontist. Periodontal exam and treatment, you take radiographs. It's going to help you see the height of the alveolar bone. You take a PA, a periapical, and bite wings. Sometimes if they have advanced bone loss, we're going to take vertical bite wings. So instead of having the bite wing this way, we take it vertical because it's going to give us more information. We probe. There's 3 readings on each side, so 6 probing depths, and you've charted that. You chart those. You know how to probe. So this is every marking in the probe is 3 millimeters. So this would be a 6 millimeter pocket. This would be a 2 millimeter pocket. Healthy, unhealthy. Instrumentation. Supragingival and subgingival plaque and calculus removed using specific instruments, and we use scalers. Sometimes you guys ask what's this called on the basic kit, and that's a scaler. But there's different scalers that we use, especially the hygienists when they're doing the scalings that clean underneath the gums, periodontal scaling. So for a prophy, which is just your basic, 6-month checkup and prophy, just polishing. There's our full mouth debridement when there's a lot of tartar and we're going to go in there and take a lot of stuff off, or scaling and root planing, and there's different instruments for each and every one of these. So for your basic, which we'll be doing today, you've got your mirror, explorer, scalers for up above the gum, your polishing paste, and your prophy cup and polishing handpiece there. If you're doing a scaling and root planing, which you're doing scaling, you're going underneath the gum tissue. Patient is numb. You need a few different instruments to get into all the different areas because you're digging into 4, 5, 6 millimeter pockets maybe. If they're deeper than that, then we're probably referring them out. But 4, 5, 6 millimeter pockets, sometimes we'll go ahead and do the scalings and try to control it here. Then we reevaluate after a month or so, see how they're doing, maybe see them back in 3 months, and if it's not looking good, then we refer. And then surgical procedures, to control gum disease. Sometimes these pockets are so deep, and these aren't done as much as before nowadays. Nowadays, if there's gum disease, instead of investing, a lot of money into some of these teeth, the teeth are taken out and implants are placed. But anyway, gingivectomy is a surgical removal of the inflamed tissue. If you have a periodontal pocket that does not respond to scaling, so you've cleaned it out, you've irrigated with medicine, and you still have a 7 or 8 millimeter pocket, you refer out to the gum specialist. They'll flap it open and maybe do cut away some gum tissue to try to minimize that gum gingival pocket so the patient can keep it clean. So gingivectomy is a surgical removal. Gingivoplasty is removal of excess tissue, but the key is you recontour. Okay, gingivoplasty, you recontour the gingiva. And the graft is when you take tissue from the roof of your mouth or somewhere else and you place it somewhere where it's needed. So just like any graft, you take it from one place and put it somewhere else. So sometimes you have like a patient who has gum recession on their canine, and they smile and they show their root, and they don't like that. Send them to the gum specialist and they'll graft some tissue from the roof of their mouth, and they'll do a soft tissue graft on the front of that canine and cover that root for cosmetics, or sometimes they're having sensitivity issues, but it can be done. Osteoplasty is the surgical removal or reshaping of alveolar bone. Again, plasty is reshaping or recontouring. Okay. Ectomy is removal. You gotta know those definitions. uni. Okay, kind of like what we showed. You're going to cut away that gum tissue. Look like that.
Seems so
That's gonna hurt
painful.
so bad later.
Yeah. That's a heavily medicated person.
Yeah.
Okay, graft. Somebody needs a graft, and here they're doing a graft because what's going on here? Can you see?
They're losing it. So
That, but how do we know they're losing it? What don't we have?
You don't have any more?
we don't have any,
Can you guys see from the back?
tissue there.
See here
You're starting to see the
and see here. What's the difference?
There's nothing. There's no tissue there.
Yeah, so this is the mucogingival junction. Okay, here we have attached gum tissue. Here we have the mucogingival junction, and we don't have any attached gum. So you can take your probe, and if you just push real hard, it'll just go right through that junction. And that's not healthy. They'll lose this teeth. So they're taking some keratinized tissue, probably from the roof of their mouth, and they're grafting it right here. And it's kind of what it would look like from the donor site. And so here they grafted it. Where did they graft? Actually, this whole thing right here is a graft. You can see how all this keratinized tissue here they didn't have here.
We'll
They
see
had-
later.
Yes, because keratinized tissue is a tough tissue. You can see here they've got these frenums kind of pulling down. Now they've had a frenectomy done, and they put that. They probably did it in a couple stages, but that's a long strip. It kind of comes around the side. Well, I don't know.
How long does something like that take to heal?
Wow. I mean, you're looking. I mean, it's got to be sore for the first. It's kind of like an ulcer, you know. For the first week, it's gonna be hurt. It's gonna hurt. So they'll put maybe like that perio covering. After about a week, then you're gonna feel the sore spot, but it won't really hurt. But sometimes they'll put like a little retainer up there just to keep it covered. Because it does hurt. Not comfortable. Again, gingivoplasty here, they're just recontouring the tissue.
Is it pain?
Healthy, unhealthy. Okay, for the lab this afternoon, we'll be doing sealants and polishing, and we'll split up, and we'll start to make some bleaching trays. So we'll do that.